How to complete a Colorado death record. Training for certifying physicians. The death record serves three distinct purposes. First, it is a legal document that serves as proof that the individual is no longer living and certifies the facts relating to the death. It also serves as a mechanism for gathering statistical information. And it is used by the Colorado Department of Health to monitor public health in our state. Second, this data is used to show the need for funding programs, studies, and research. Finally, the death record, or death certificate, is needed by the legal next of kin in order to proceed with a variety of legal matters. As of August 7, 2023, all death records on natural cases, except as defined in coroner statutes, must be filed by the decedent's primary or attending physician, as stated in Colorado Revised Statute 25-110. Who should sign the death certificate? Was this your patient? Were you prescribing medicine? Had you treated the patient for an illness or condition that could result in death within the 12 months preceding the death? If you answer yes to any of these, then you are the best person to be completing the medical certification. Many doctors have physician assistants or nurse practitioners who see and treat their patients. However, they are not legally authorized to certify death. You are. Even if you have not personally treated or seen the patient, your PA or NP is working under your supervision. You should consult with your PA or NP and review the medical records for the best possible cause. The legal authority to certify the death still lies with you. Any practicing physician who has access to the patient's medical history and medical records may certify the death. Should the attending physician wish to add information at a later date, they can file a medical amendment affidavit as long as their name is listed on the record as the attending physician. This includes primary physicians, ER doctors, and specialists. Yes, emergency room physicians can and should certify deaths. Specialists can also sign death records if they had treated the patient within the 12 months preceding the death. Quite often, a patient with a chronic illness will concentrate treatment with a specialist once diagnosed and may not make regular visits to a primary care physician. The specialist would then be the one with the best knowledge in those cases. The statute grants you 72 hours upon receipt of the record to complete and certify the cause of death. The majority of deaths occur from natural causes and should be certified by a private physician. In these instances, the death record is initiated by a funeral director. The funeral director will meet with the decedent's family to gather all of the required demographic information. The funeral director obtains physician names from the family. They will contact you to verify that the decedent was indeed your patient and to confirm that you will certify the death. If you do not currently participate in EDR, the funeral director will ask you for your fax number. Online certifiers will receive an email notification that the record is now available to complete and to certify the medical information. Offline certifiers will receive a fax attestation for completion of the cause of death. If the funeral director encounters delays in sending you the record, you are not penalized for circumstances beyond your control. You still have a full 72 hours to complete your portion of the death record. When everyone has completed their assigned actions, the record is filed as registered incompleted. Most Colorado death records are filed electronically using EDR, the Electronic Death Registration System. There are two ways physicians certify the medical portion of the death record, online or offline. Offline physicians are sent a fax for completion of the medical information. The funeral director begins the death record in the EDR and sends the fax to the physician. The physician completes the medical portion and faxes the form directly to EDR, not back to the funeral home. The funeral director receives an email that the fax has been returned and types in exactly what the doctor wrote on the fax. If needed, the record is available for certification immediately after it is saved and registered as completed. With online physicians, the process is more efficient. The funeral director creates the death record and completes all of the demographic information. The physician receives an email notification that the death record is ready for certification. The physician logs into EDR and completes the medical information. All coroners are online users and are able to create records in EDR. The coroner's office can either file the entire record or assign it to the funeral home chosen by the family after the medical portion has been completed. The physician is guided by Chapter 25 of the Colorado Revised Statutes, and it defines several factors for how the death record is created and filed. Again, the time frame of 72 hours is granted to the physician once they have received the record from the funeral director, regardless of the date of death. The majority of death records are signed by the primary or attending physician. Coroners are only authorized to certify deaths as defined in Colorado Revised Statute 30-10-606. Note that the law requires that all licensed physicians must be EDR users no later than March of 2024. What is a coroner's case? Deaths involving external causes or trauma as defined in Colorado Revised Statute 30-10-606. Unattended deaths should not be confused with home deaths. This is a distinctly different situation. Primary or attending physician means a physician who treated the decedent through examination, medical advice, or medication during the 12 months preceding the date of death. Treating a patient is not limited to how many times you've seen that patient personally, or whether or not that patient was compliant with your directions. Refilling prescriptions is considered treating the patient, even though you may not have physically seen the patient for a few months or were not present at the time of death. This patient is still under your care, and should death occur, you would be required to certify the death. Let's talk about this a little more in depth. Unattended means that there is no clear evidence of treatment by a physician within the last 12 months or more. A physician is considered unable to sign when traveling, they have left the practice, retired, or died. Unwilling is a failure to perform your statutory duties and may be considered unprofessional conduct. Unable and unwilling are two different things. What if the patient dies at home? Just because a patient dies at home does not make it automatically a coroner's case, nor does it mean that an autopsy must be performed. Have the coroner's office and law enforcement investigated to determine there is anything suspicious about the death? If the coroner determines there is no reason to take jurisdiction, then it becomes the responsibility of the physician to certify the death record. Natural deaths should be certified by the attending or the primary physician. The physician does not need to be present when the patient actually dies, because the physician is not always with the patient at the exact time of death. Cause of death can be determined by review of medical records and what you believe to be the circumstances of the death. What were you treating the decedent for? Was there a likelihood that the patient could possibly die from the disease or condition from which you were treating them? If the physician is not comfortable making an exact diagnosis, terms such as probable or possible can be used. The law and the death record itself indicate that the certifier determined the cause of death with a reasonable degree of medical certainty. This level of certainty is equal to more likely than not. So, what's the importance of cause of death data? Causes of death help in identifying trends in mortality and possible public health threats. As the medical professional, the data you provide is based on your treatment of the patient and clinical events. Your professional experience should result in the most accurate etiology based on your best knowledge of the patient. Let's review some examples of case studies and walk through how you would complete these particular cases. Your patient, a 52-year-old male, was last seen in the physician's office about 2 months prior to death, at which time he had no complaints. He was being treated for hypertension and hypercholesterolemia. He last filled his prescriptions 1 week prior to death. The evening prior to his death, he began to complain of epigastric pain and took several Tums. He was found dead in bed the next morning. The primary care physician was concerned because he did not know exactly how the patient died since he was doing so well. Regardless of the comfort level of the primary physician, they were treating the patient at the time of death, prescribing medications, and they knew the patient better than anyone else. Is this a coroner's case? Based on the clinical history of the patient in this scenario, probable acute myocardial infarction should be entered as the possible immediate cause of death, with coronary artery disease as a possible underlying cause. The manner of death is natural based on the patient's clinical history. This should not be a coroner's case. The physician should sign the death record. Case study number 2. Your patient, an 89-year-old white male, presents to the ER with chest pains and he rapidly codes. He has a medical history of hypertension, coronary artery disease, diabetes, emphysema, renal insufficiency, diverticulitis, and osteoporosis. With such a list of possible causes, what would be the best choice? Despite the many ailments that this patient endured, not all of them were significant contributions to his death. Is this a coroner's case? The immediate cause of death would be acute myocardial infarction due to coronary artery disease due to hypertension. The other contributing factors should be listed under Part 2. Under Other Significant Conditions, notice that we have only listed the top 3. Osteoporosis was not considered a contributing factor because decreased bone density did not contribute to his death. Simply put, line A, cause of death could be stated as hypertensive cardiovascular disease. Case study number 3. Your patient, a 46-year-old male who was shot in the back 20 years ago, develops an infection in the wound which leads to MRSA. The patient succumbs to the infection 4 days after diagnosis and dies in his sleep. Is this a coroner's case? Yes, this is a coroner's case. The coroner would enter MRSA as the immediate cause. Complications of gunshot wound is the intermediate cause. The manner of death is homicide. Although this patient's injury occurred 20 years ago, his death was a consequence of that injury and is considered a trauma-related death. Only a coroner can sign the death certificate as anything other than natural. Case study number 4. Your patient, a 66-year-old female with metastatic lung cancer, is admitted to hospice for palliative care. She is bedbound and pain is manageable. She then complains of increased pain and swelling in her left leg. She does not want to go to the hospital or have it evaluated, realizing it could be a deep venous thrombosis, complication that is potentially fatal. He dies in bed shortly after developing these symptoms. This is a case of natural causes. Is this a coroner's case? The immediate cause would be possible pulmonary embolism. The intermediate cause was the deep vein thrombosis. The underlying cause is the metastatic lung cancer. The manner of death should be natural. Case study number 5. A 60-year-old male had been admitted several times before for complications of cirrhosis, including hepatic encephalopathy and upper gastrointestinal hemorrhage secondary to esophageal varices. Lab studies confirmed hyperammonemia and elevated liver enzymes, as well as anemia with an elevated MCV. Within an hour of admission, he coded and medical intervention was unsuccessful. When reviewing the case history, there is no clear consequence of events outlining what led to the death of the patient. Cardiopulmonary arrest is a mechanism of death, not a cause. Massive ascites and jaundice are symptoms or signs. Hyperammonemia is a lab finding. Is this a coroner's case? After applying the principles of review and considering the immediate cause, of hepatic encephalopathy and cirrhosis of the liver, the underlying cause of death would be complications of chronic ethanol use. This is a natural death. Case study number 6. A 56-year-old male presents to the emergency room with massive hematemesis. Despite aggressive resuscitative efforts, this patient died within 1 hour of admission. He last saw his primary care physician approximately 8 months prior to death, but he had refilled a prescription written for lisinopril 2 weeks prior to this event. He had 4 ER visits in the past 2 months for bleeding, varices, and was well known to the ER staff. If the ER physician had made a diagnosis, he or she should sign the death record. If no diagnosis was made, the primary care physician should sign this record based on the clinical history and also because the prescription refill was evidence that she was treating him. It must be restated that ER physicians can sign death records. Statute allows for the physician in attendance immediately before the death to sign the death record. If they make a diagnosis prior to death, or they have sufficient history on the patient, the ER physician can determine more likely than not why the patient died. Is this a coroner's case? The patient passed away due to the myocardial rupture, which is the immediate cause of death. The cause of the rupture, or the intermediate cause, was the acute myocardial infarction that preceded it. So what caused the myocardial infarction? The coronary artery thrombosis, and what caused that, ASCVD, is the underlying cause of the process. Those would be listed on the death record in the same order as we just defined. Please be specific when completing the death record. Vital statistics will reject unacceptable causes of death such as cardiac arrest, cardiopulmonary arrest, respiratory arrest, undetermined, or unknown. Remember, the mechanism of death is not an acceptable cause of death for certification purposes. Cases involving falls. An 80-year-old female fell at home and fractured her hip. She was discovered by her caretaker several hours later and transported to a local hospital. An ORIF procedure was performed and she was discharged 10 days later. Since the surgery, she has been eating poorly, became lethargic, and required hospice care. She died in bed 3 weeks later. People who die following a progressive downhill course following an injury fall under the coroner's jurisdiction. The question that should be answered is, would the patient be alive today had the injury not occurred? If the answer is more than likely yes, then the case falls under the coroner's jurisdiction. The coroner may review the medical records in this type of case to determine if an examination is necessary. Do not tell the patient's families that an autopsy will be performed on a coroner's case. This may or may not be true, and it could result in conflict between you, the patient's family, and the coroner. Only the coroner or district attorney can determine if an autopsy is warranted. Here we have a similar case in that both women were of like demographics and age. They both underwent the same procedure and were discharged within the same time frame. The difference here is that our second patient, unlike the first, did not begin a downhill slide. In fact, the opposite. She returned home and resumed her normal daily activities. She was eating properly and from all outward signs had completely recovered from the surgery. This case would most likely be declined by the coroner. She was doing well after surgery and was suffering no ill effects and had passed the common risk period for pulmonary thromboembolism, bedbound pneumonia, and other common complications. As her doctor, you would certify this death based on her history. She most likely suffered a cardiac event which had nothing to do with the surgery. You would not need to list the hip fracture on the death record, as it clearly had nothing to do with her death. This is not a coroner's case. Other medical items. Surgeries. There are times when surgery is a part of the consequence of events that lead to the death of a patient, and surgery should be mentioned when reporting the death. In these cases, the physician must provide information about why the surgery was performed and the date of the surgery. If there's a problem during the surgery or there is a negative outcome related to the surgery, it must be reported to the coroner or medical examiner. although it does not necessarily become a coroner's case. Each case is reviewed based on its own merits. Tobacco. It was more than 50 years ago that the 1964 Surgeon General's report first put the adverse health effects of smoking into the public eye. To further improve the quality of data on how smoking increases mortality, we need to know if tobacco contributed to the death. Pregnancy questions should be completed for all female decedents. Pregnancy can be an important factor with deaths among women of reproductive age. Pregnancy within the year preceding the death should also be noted. Accidents or injuries are usually from some external cause, and these are considered to be coroner's cases. The filing of a medical amendment affidavit is still a paper process. Results from autopsy findings and any new medical information can be added or changed by the certifier through the use of a medical amendment affidavit. If the certifier was covering for the attending physician and the attending's name is entered on the record, the attending physician can also amend the death record. The coroner can amend any death record when the death occurs in his or her district should the information indicate that the case falls under their jurisdiction. There is no fee charged for a medical amendment affidavit, and there is no time limit to correct a death record. There are legal consequences if statutory requirements are not met. A physician refusing to sign a death record without reasonable cause may be in violation of the statute. The state may also consider the violation an act of unprofessional conduct, which can be reported to the Department of Regulatory Agencies against a licensee. We've covered some very important aspects of certifying causes of death. Colorado Revised Statute governs the realms of vital statistics and how death records should be filed. As the physician, you are the most knowledgeable person on the decedent's health and well-being and should determine the cause of death and certify those facts onto the record. Physicians are always welcome to contact the coroner's office if they have questions when drafting cause of death statements, as they are the subspecialists in death certification. Finally, remember that this is a person that you saw and treated in the past, and the time has come that they cannot ask for your help. It is your duty to provide this final service for them. This allows closure for the family to move through their grieving process. If you'd like to explore this topic further, there are several good resources available for you. The Department of Vital Records will have the most information related to EDR access and the death certification process in the state of Colorado. The CDC provides a physician's handbook on death certification as a medical certifier. You may also find more information about death certification through the College of American Pathologists. Thank you for your attention.